Okay, guys. So we are going to be working on chapter 11 today, airway management. There's a whole lot of information. Then we're going to jump over to, I think, chapter 16. Looking at my book here, respiratory emergencies. So they tie kind of in with each other, and we're going to try to go that route and see if it makes more sense. So let's get started. Some of the things we're going to discuss: airway anatomy, airway assessment, and techniques to ensure a patent airway. So keeping that airway open. Respiration, the anatomy of the respiratory system, we've already kind of went over a little bit. Physiology and pathophysiology of respiration, pulmonary ventilation, oxygenation, and respiration, that's external, internal, and cellular. So respiration, the assessment and management of adequate and inadequate ventilation, supplemental oxygen therapy. Artificial ventilation, the assessment and management of adequate and inadequate ventilation, artificial ventilation, minute ventilation, alveoli ventilation, the effect of artificial ventilation on the cardiac output. The pathophysiology applies fundamental knowledge of the pathophysiology of respiration and perfusion to a patient assessment and management. So, the primary component of caring for a patient is ensuring that they can breathe adequately. When the ability to breathe is disrupted, oxygen delivery to the tissue and cell is compromised. Oxygen reaches body tissue and cells through breathing and circulation. Remember that cardiac and respiratory, they're married, they're together. One messes up, the other one's going to mess up. So we've already went over a lot of this. Your upper airways, your lower airways. So we start nasopharynx, nasal air passage, your pharynx, oral pharynx, mouth, epiglottis, and your larynx. Then we've got the trachea. It starts our lower airway, apex of the lung, top of where the lung's at, our bronchioles. Um, so it goes trachea. It's going to actually drop down to your carina, which is that dividing point, where we go into our right and left lung. And then we've got our main bronchioles. Those are if you remember, I kind of described it as a tree. That's going to be your tree trunk, those bronchioles, our main bronchus. And then we go into our bronchioles, which are going to be our branches. These are what branch out. And then at the end of that, you've got your alveoli, which, if we're using the tree method, those are your leaves. Um, And just like a leaf has veins, your alveoli has capillary beds around it. This is where that oxygen and carbon monoxide diffuse in and out of the alveoli. Um, and we're going to get into all that. Knowing your upper airway anatomy and your lower airway anatomy is very important. Um, we discussed how the diaphragm works. If you have questions on that, let me know. The respiratory system consists of all the functions that make up the airway and help us breathe and ventilate. The airway is divided into upper and lower airways. Once again, knowing your upper airway and your lower airway is key here. Nose, mouth, oral cavity, pharynx, larynx. The upper airway's main function is to warm, filter, and humidify air as it enters the body. So you need to remember that. Um, the upper airway, that's where everything starts to come in. Um, and just remember it warms, it filters, and it humidifies. The pharynx, it's a muscular tube extending from the nose and mouth to the level of the esophagus and trachea. It's composed from top to bottom with the nasopharynx, oral pharynx, and the laryngopharynx. So your nasopharynx filters out dust and small particles, warms and humidifies air as it enters the body. Your oral pharynx, posterior position of the oral cavity. The epiglottis is superior to the larynx. So remember that epiglottis is that leafy shaped thing in the back. I don't want to spend a whole lot of time here. I want to point out the size of the tongue. Um, there we go. I want to point out our epiglottis right here. It's our flap that will close if we need it to. Let's see. Auditory tube is up here. Nasopharynx. So here's your nose, nasal cavity. Right here's your nasal pharynx. So if this is your mouth, your oropharynx is here, epiglottis. Your larynx, complex structure formed by many independent cartilage structures. Marks where the upper airway ends and the lower airway begins. That is important to remember. Got your cricoid cartilage. Here's your trachea and then rings we talked about in class. Larynx, thyroid cartilage forms a V shape anteriorly. The cricoid cartilage is the first ring of the trachea. The glottis is the area between the vocal cords. The lower airway function is to deliver oxygen to the alveoli. Lower airway actually includes your trachea, bronchi, and lungs. Sorry, checking my phone was getting inactive. Trachea, conduct conduit for air to enter into the lungs. So your trachea is where air goes. Divides into the at the carina into two main stem bronchi, left and right. So we go down our trachea, we hit that carina, which is the dividing point left and right, and it goes into our bronchi, into our left and right lungs. The bronchi is supported by cartilage. Bronchi distributes oxygen to the lungs. So our windpipe, our trachea right here, our carina is that dividing point. It goes into our main bronchi, which is the trunk of our tree. Smaller bronchi is the branches. Bronchioles, even smaller. And then it actually ends down here at the end of each one of those bronchioles with the alveoli. The trachea, bronchioles are made up of smooth muscles. Um, Smaller bronchioles connect to the alveoli. Oxygen is transported back to the heart and distributed to the rest of the body. So we breathe in, oxygen goes in, upper airway, down through our lower airway, into our main bronchi, on the left and right. Bronchioles, it goes through the lungs to our alveoli. The alveoli, oxygen enters, carbon dioxide actually exits. It diffuses into those capillary beds where it is pushed back to the heart and then distributed to the body. So we have fresh oxygenated blood. Trachea, the vena cava, um, bronchus, lungs, heart, diaphragm, aortas. We've kind of talked about all this in other chapters. So the heart's the greatest vessel, vena cava, and aorta are found in the thoracic cavity. We talked about how the lungs work and how the diaphragm works. When that diaphragm contracts, everything opens up. It makes room for our lungs to expand. Our rib cage expands. When the diaphragm relaxes and goes back into its natural position, is when we exhale. Our rib cage closes back to natural form. Our lungs, they never fully collapse because we've got that dead space air in there. But um, they do shrink down, and we just continue this process. So the metasternum contains the heart, the great vessels, the epiglottis, or I'm sorry, the esophagus, the trachea, the major bronchi, and many nerves. So remember our mediastinum sternum is in our center right here. This is where it's at, inside that sternum area. The respiratory and cardiovascular system work together. I don't know how many times we've talked about that. Ensure a constant supply of oxygen and nutrients is delivered to cells. It removes carbon dioxide and waste products. So you do need to know these. We talked about them in class. Ventilation is the physical act of moving air in and out of the lungs. Oxygenation, the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. And then respiration is the actual exchange of oxygen and carbon dioxide in the alveoli as well as tissues in the body. Ventilation is the physical act of moving air in and out of the lungs. Inhalation, it's active, muscular part of breathing. So when we inhale, that is the active part of breathing. The diaphragm and intercostal muscles contract. Um, this generates a negative pressure in the thorax, allowing air to enter. Um, Again, on inhalation, the lungs require the movement of the chest and supporting structures to expand. Partial pressure, the amount of gas in the air or dissolved in fluids like blood. And then oxygen and carbon dioxide both diffuse until the partial pressure in the air and blood are equal. So that diffusion is going to take place until there is a balance. Mechanism of ventilation can be illustrated by using a bell jar, um, exhalation and chest contraction, anatomic. We just need to do this in class. It would make a lot more sense if I did that. Inhalation, um, inspiration delivers oxygen to the alveoli. So when we breathe in, we know we're taking in oxygen. Tidal volume and dead space, we've talked about a little bit. Um, Exhalation does not normally require muscular effort. Passive process. The diaphragm and intercostal muscles relax. Smaller thorax compresses air into the lungs. Um, so this is the passive process. This takes no effort from the body. Everything is returning to its normal function. I think the example I gave at one point was if you remember those little toys when we were kids, and I'm old, so some of you might not remember. There was a little rubber dome toy that you'd push down, like on the table, and it would slowly raise up and then it would shoot up in the air. If you know what I'm talking about, this will make sense to you. That's essentially the same thing. You had to manually make it go down, which essentially would be our diaphragm going down, allowing us to inhale, but then it naturally would return to its dome shape, um, which would be that passive process. Regulation of ventilation involves a complex series of receptors and feedback loops, which we've kind of talked about a little bit in chapter 6. The failure to meet the body's need for oxygen may result in hypoxia. Based on pH changes in the blood and the cerebral spinal fluid, the hypoxic drive, which we discussed, is what drives us to take a breath. It's measuring carbon dioxide in our body system, typically seen in patients with end-stage COPD, which we've discussed a little bit in class. We'll get deeper into that though. Um, Oxygenation, uh, processes of loading oxygen molecules onto hemoglobin molecules in the bloodstream. So this is where that diffusion, that oxygen is binding to that hemoglobin. It requires the internal respiration to take place. Does not guarantee that internal respiration is taking place. Ventilation without oxygenation can occur where oxygen levels have been depleted. Respiration Actual exchange of oxygen and carbon dioxide in the alveoli and tissue of the body. Cells take energy from nutritions um, through metabolism. So the external respiration, pulmonary respiration, it brings fresh air into the respiratory system. So we take that breath, exchanges oxygen and carbon dioxide between alveoli and blood in the pulmonary capillaries. So we went over this 1,000 times. The balloons, the little balls, whatever you want to call them, that's your alveoli. This web around them is your capillary beds. You see your pulmonary arterioles right here, this bigger one that falls down into our capillary beds. Pulmonary venules right here. So what happens is that oxygen goes into the alveoli, CO2 is coming out. Oxygen is then diffused into our capillary beds, right? It's pushed, it goes out. It's crowded in here, so it goes to the area of lower concentration, higher concentration, the lower concentration. From there is when it goes up, back up to our heart in a cycle because it's been oxygenated. Internal respiration, exchange of oxygen and carbon dioxide between systematic circulation systems and cells. So oxygen and nutrition is going in to the tissue and cells, right? We're in a capillary, right? Oxygen goes into the cells, that used up carbon dioxide is leaving the cell, hitching a ride back to the alveoli, where it can then be offloaded and we breathe it out. That was a whole lot right there that's kind of really confusing. Um, we're going to go over this in class very in depth. I really don't know the best way to explain it on here, though. Factors in the nervous system, chemoreceptors monitor levels of oxygen, carbon dioxide, hydrogen ions, and pH and cerebral spinal fluid provide feedback to the respiratory center. So before we go any further, I'm going to time out. I want to go back for a second. If this does not make any sense, I'm going to ask you to please go to my YouTube channel. There's one towards the bottom. I don't even know what it's called. It's Airway something. It's not built off of any slides like this. I made it myself. The way I describe respiration at the alveoli level is on there, and it might make more sense. So before we go any further, if you don't understand the process of oxygen entering the alveoli, moving over to the capillary beds, going to the heart, to the rest of the body, please go watch that other video. It's 12 minutes long and it breaks it down a lot better than this does. Okay, sorry. Moving on. Um, so remember those chemoreceptors monitor the levels of oxygen, carbon dioxide, hydrogen ions, and pH in the cerebral fluid. And it tells us what we need or we don't need. Ventilation, perfusion ratio, and mismatch. So air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. Failure to match in the case of most abnormalities of oxygen and carbon dioxide exchange. This is that VP mismatch we talked about before. Ventilation and perfusion ratios and mismatch. Gas exchange does not take place. Lack of O2 in the bloodstream. CO2 is recirculated in the bloodstream. Severe hypoxemia can occur. So if we have a mismatch, then we are not going to get the carbon monoxide to leave the body. We're not going to get that oxygen to go onto the hemoglobin. So we're not actually going to cycle the blood through the oxygen through the blood. And so now, if you'll remember, it's not medically correct at all. What I call clean blood and dirty blood. Clean blood is oxygenated, dirty blood is carbon monoxide filled. Now we are going to be cycling that dirty carbon monoxide filled blood back through the body. So what's the problem is if we don't have that oxygen and nutrition, then we're not feeding our cells, our tissues. Um, Carbon monoxide's already been kicked out of those cells and tissue. So when it goes back around, we are literally starving cells and tissue. Factors affecting pulmonary ventilation, um, infections, allergic reactions, unresponsiveness like a tongue obstruction, things like trauma. Some of the external factors, atmospheric pressure, partial pressure of O2. So this could be elevation changes. This could be diving, like deep sea diving or whatever. Um, this could be inside a confined space with low oxygen. Um, some of the internal factors are like pneumonia, pulmonary edema, COPD, or emphysema. So there's already damage to those alveoli, or those alveoli are surrounded by fluids. Your airway, your bronchioles are full of just junk, and mucus membranes, and the air is not actually passing through them like it's supposed to. Circulatory compromise. Trauma emergencies can obstruct blood flow to individual cells and tissues. So simple or tension pneumothorax, open pneumothorax, hemothorax, hemopneumothorax, which we're going to discuss all of those in class. If someone out there is watching this and you're not in my class, just get on YouTube and go look up some of these terms. It's when air is outside, air or blood is outside the lung, pushing in, and it can cause a collapsed lung. Um, It can be a puncture to the lung, and air is leaking out into the chest cavity, putting pressure on everything else. Just go watch some videos on it, go look it up. In class, we're going to go over these one by one. Circulatory compromise, other causes, um, blood loss. If we don't have the fluid to pump, we got a problem. If we don't have the fluid to carry the oxygen, we've got a problem. Anemia, once again, lack of blood or low blood count. Um, Hypovolemic shock, vascular dilatory shock. Yeah. Um, so our patient assessment, um, aerosol generated uh, procedures, AGPs, CPR, um, nebulizer treatments, endotracheal intubation or ET tubing, continuous positive airway pressure, recognizing adequate breathing. So between 12 and 20 breaths per minute is normal for an adult. Regular pattern of inhalation and exhalation. So we need to look for that regular. We talked about in our last chapter in patient assessment. Are they breathing normally? Is it adequate? Um, Bilateral, clear, and equal chest sounds. That's why we listen to chest sounds. You listen to the left, you listen to the right. If you listen to lower left, you listen to lower right, and you just bounce back and forth and compare side to side. Regular, equal chest rise and fall. We kind of talked about adequate depth and tidal volume. Is it normal? Are they working to breathe? Is it really shallow? Are they just taking really deep breaths? Those are things we need to pay attention to. Once again, recognizing abnormal breathing. Fewer than 12 breaths a minute. More than 20 breaths a minute. Irregular rhythm. Diminished, absent, or noisy auscultated breath sounds. Reduced flow of expired air at the nose and mouth. Recognizing abnormal breath sounds again is unequal or inadequate chest expansion. Increased effort of breathing. Shallow depth. Skin that is pale, cyanotic, cool, or moist. Skin pulling in or around the ribs, above the clavicles during inspiration. So when we did our patient assessment on Tuesday, we discussed all this. This would be work of breathing. This would be signs that we can see. Um, you start noticing these things as soon as you arrive on scene and you make eye contact with your patient. Sometimes it's not overly obvious. Sometimes it's super obvious when you walk in and you see a patient and they're in tripod position, or they are laying on the couch and you can actually hear them trying to breathe from across the room. These are the kind of things that we need to immediately notice, um, and start taking action on. Remember, ABCs, well, airway and breathing go hand in hand. Circulation is right there behind it, so ABCs are critical. So any of this that we see, this inadequate breathing, we need to do something. A patient may appear to be breathing after the heart has stopped. It's called agonal gasp. Cheney stroke respirations are often seen in patients with stroke or head injuries. Um, so these are kind of hard to, they can be hard to understand because there are several different types of breathing patterns. Um, we will just we'll turn on some Cheney stroke respirations in class and you can listen to them. If you're watching this and you're not in class, once again, go to YouTube or Google and just type that in, that Cheney stroke breathing, and you can actually listen to it. Um, it's the pattern and the sound that you're gonna notice. I'm gonna jump back up to agonal gasp. If you've never seen this, it's just a and there might be 10 seconds, there might be 20 seconds, there might be 35, 40 seconds before that next one. This is not breathing. This doesn't count as a respiration. Yeah, here's some more. The ataxic respiration, irregular or unidentifiable pattern, may follow a serious head injury. The Kussmaul respirations, deep, rapid respirations, common in patients with metabolic acidosis. Patients with inadequate breathing need to be treated immediately because these are not getting the perfusion done. They're not getting actual respiration at the alveoli or cellular level. It's not taking place like it should. Assessment of respiration. Even though the patient may be ventilating appropriately, respiration may be compromised. Level of consciousness and skin color are excellent indicators of respiration. That's why I keep harping on we need to check AVPU. Every time we do a vital, every time we do an assessment, we check AVPU. And skin color is why we need to lay our hands on their arm or on their hand. We need to check that temperature. We need to check, are they dry? Are they moist? Um, Skin is a huge teller, especially in cardiac and respiratory. Also consider oxygenation. The pulse oximetry is considered a routine vital sign. It can be used as part of any patient assessment, and it should be. Um, we have a patient assessment. We do our skill sheets, but I'm going to go ahead and tell you right now that one of the first things I do if I walk in and it's a respiratory call, I make contact and I put that pulse ox on them before I do anything else because I can be reading that pulse ox why I'm getting my history, why I'm doing my patient interview, if you will. Um, there's nothing wrong with after BSI, scene safe, all of that. I make my contact. There's nothing wrong with if they give me permission to treat, go ahead and just stick that cap note or that pulse ox on them right off the bat. Measurement of maximal CO2 at the end of an exhaled breath. Low CO2 level, hyperventilation, decreased CO2, return to the lungs. Reduced CO2, uh, production at a cellular level. High CO2 levels, ventilatory inadequacy, apnea, so lack of oxygen. Measured using the capnography or the CAPNO device, which we're going to talk about in class tonight. Normal range 35 to 45 can be used to spontaneously breathing patients with a special nasal cannula. It's a nasal cannula that has a little monitoring device under it. Um, it's going to give us a waveform that we can actually see on our monitor. To we can almost see what's taking place in the lung every respiration. We can tell if they have good um, intake and exhalation of oxygen. It's going to read that um, CO2 reading for us, so we know if they are withholding carbon dioxide, if they're blowing off too much carbon dioxide. Because once again, remember, our body doesn't measure how much oxygen we have. Our body reacts to the carbon monoxide level. Um, Using that hypoxic drive, um, it's going to decide if we need to take a breath, how often, how deep. Emergency medical care begins with ensuring an open airway. Rapidly assess whether a patient is unconscious, has an open airway, and is breathing adequately. Position the patient correctly. Supine position is most effective, depending on the situation, but yes. Um, is their airway open, or do we need to open it for them? Unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. We've discussed this multiple times. Right here's a perfect picture. That tongue is fallen back. He's unresponsive, so everything relaxes. When we go unresponsive, our body relaxes. So that tongue is a muscle. It falls to the back of the throat and it blocks our airway. That's why we use non-traumatic head tilt chin lift or traumatic with possible spinal or neck injury. We use the jaw thrust maneuver. Head tilt chin lift, we've discussed this in class. For those of you who don't know it, it's exactly what it sounds. You notice that he puts his hand on his head and his chin, and we are going to gently lift the head back, which kind of lifts the chin up, and it's going to pull that tongue off the back of the airway back here. This does not maintain an open airway. This opens an airway. At unresponsive like this, if they're not breathing well, or you do a head tilt chin lift maneuver and they don't start breathing, this is where we're going to go with that OPA or MPA, which we really haven't talked a lot about, and we will probably start bagging them if needed. But all that head tilt chin lift does is pulls the tongue off the back of the throat. It does not ensure you keep an open airway. With patients supine, okay, we're not going to talk about that. That's what I just explained. So the jaw thrust maneuver, this is when you suspect a cervical spine injury. This maneuver is so we can open that airway. We move that tongue without moving the neck or the spine. Where head tilt chin lift, we're actually moving the neck. Where jaw thrust, we are actually manipulating the muscles without moving the neck, so we can still pull that tongue up. Kneel above the patient's head. Place your fingers behind the angle of the jaw. Move the jaw forward. Use your thumbs to help position the jaw. So right there on the angle of your jaw, where your jawbone curves, we are actually going to pop out that, we're not popping out the jaw, but we're moving it forward or outward, and it will lift that tongue out of the airway. It is very difficult also on a lot of people. Even though the airway is open, the mouth may be closed. Use a cross finger technique. This is where you can take your fingers and go in, you place them on the edge of the teeth, and you twist, and it will open the mouth. So here they're showing that jaw thrust maneuver. Find the angle of the jaw, and they are manipulating the jaw, not the neck at all. So we open that airway and we notice that there's stuff in there. Vomitus, blood, secretions, whatever it might be. You may need to suction that out before we start giving uh, breaths to this patient. So you've got to keep it open all the time. There's different suctioning tools, the portable, hand operated, and fixed equipment is essential for resuscitation. So you're going to have something similar. There's a bunch of different types out there. So this is a portable suction. It's a manual suction. You pull that handle and release it, and it causes suction, and it will suck that stuff out of the throat. You've got a fixed suction. This is what you're gonna find in most of your ambulances. Um, you turn it on. He's got his rigid cathode suctioner here. He's got his tubing, and this is your actual vacuum tubing right here. And so we turn this on, we start suctioning, it goes through our tubing into our holding container. And then this is another type of portable. It's battery powered. We keep these on the units too. Um, Same thing as this, but this is a handheld carried one. A portable or fixed unit should have a wide bore, thick walled, non-kinking tube, plastic, rigid, pharyngeal suction tip, non-rigid plastic catheter, a non-breakable disposable collecting bottle or that container where everything goes, water supply for rinsing the tip. So the processes to this sectioning, we want to inspect the equipment regularly. We check it every day on our truck checks. To operate the suction unit, I'm going to tell you right now, if you're just starting out and you get on with someone, go ahead and go play with that. Make sure you understand how to turn it on, and how all the equipment hooks up. Make sure you know how the tubing hooks up. Um, Check the unit for proper assembly of its parts. Test the suction unit to ensure vacuum pressure of more than 300. So remember that. Um, Select and attach the appropriate suction catheter to the tubing. And the reason it says that is we have our rigid catheter suction. There's also the newer one out there, the Decanto or something. It's a little bit different shaped. It is a rigid catheter suction. Um, there's also the French catheter suction or the non-rigid, same thing. And it can be thread like through an eye gel. It can be thread down through an ET tube and suction those out if we need to. They're like a flimsy straw, and they come in multiple sizes. Um, Never suction a mouth or nose for more than 15 seconds at a time for an adult. 10 seconds for a child, 5 seconds for an infant. Suctioning can result in hypoxia. So, one, we've got a blockage, so oxygen's not getting in to begin with. And if we just sit in there forever suctioning, whatever oxygen might still be in there, we could actually be pulling out. Um, it might talk about it. I'll wait. Um, When patients have secretion or vomitus that cannot be suctioned easily, remove the catheter suction from the patient's mouth. Log roll that patient to their side. Clear their mouth carefully with a gloved finger. So if there's big old chunks of nasty stuff in there, we can roll them on their side and we can scoop it out. Um, if the patient produces a frothy secretion as quickly as you can suction them, suction the airway for 15 seconds, less in infants and children. Ventilate for 2 minutes. Continue this alternating pattern until all secretions have been cleared. Sometimes you just can't keep up with it. What it's saying though is it's that frothy, nasty stuff. This isn't vomitus. This isn't blood. This is just a frothy, um, bubbly type stuff. Um, Suction what you can. We need to ventilate because every second we're not ventilating, we've got cells, tissue, and brain death occurring. So what it's saying is get what you can out, get some oxygen back in them, and then let suction again. It's kind of a gray area. It's really tricky. Um, Before I move any further forward, let me think if there's anything else I want to add to that. So the process, um, we know we're going to suction. We've made up that decision. Um, we never suction when we go in. So there's no suction. We insert our suction catheter or our rigid suction catheter. We apply suction once we're towards the back of the mouth. You either work side to side or circular motion on your way out, applying suction. So we do not apply suction going in, only when we come out. Um, Basic airway adjuncts. So prevent obstruction by the tongue and allow passage of air and oxygen to the lungs. Oropharyngeal airways. Keeps the tongue from blocking the upper airway, make it easier to suction the oral pharynx. So OPAs, MPAs. Um, these two things tie in with the head tilt, chin lift, or jaw thrust. I told you that when you do one of those maneuvers, it does not ensure an open airway. So when we do one of those maneuvers, if the patient does not begin breathing, then we can use the OPA, oral pharyngeal airway, or the MPA, which is the naso oral pharyngeal airway. Um, the OPA will go in and actually holds that tongue off the back of the throat, which allows us to, one, ventilate that patient, and two, suction as needed. We're not worried about holding their head so that their airway stays open. The OPA will hold that tongue out of the way for us. MPA is a little tube that will insert through the nose, go to the back of the throat, bypassing the tongue. And once again, it ensures that we have something we can give ventilations through. Um, it bypasses the tongue, so we are ensured some sort of airway passage. Um, so the indications for an OPA or an oral pharyngeal airway is an unresponsive patient without a gag reflex, apneic patients being ventilated with a bag mask device. If we are going to bag a patient, we need to attempt an OPA, oral pharyngeal airway. It's this hard plastic thing. It's kind of curved. Um, I wish I had one to show you, but I don't. Um, it goes in the mouth. We turn it over the back of the tongue and it drops into the back of the throat or back of the mouth to hold that tongue out of the way. If they gag, we cannot use the OPA. If they gag, we have to go with an MPA. If there's no gag reflex, OPA is the way to go. We don't use them on conscious patients. Any patient who has an intact gag reflex, we don't use. The MPA, it's used in patients who is unresponsive or has an altered level of consciousness, um, has an intact gag reflex. So if they gagged on the OPA, we have to try the MPA. Is unable to maintain his or her own airway spontaneously. So if they are unresponsive or they have altered level of consciousness, um, and they're not able to breathe on their own or maintain their breathing, then this is when we'll use this. We do not use this if there is severe head injury with blood in the nose, history of fractured nasal bone. Um, so if we have facial trauma or damage and we have bleeding from the nose or history of nasal fractures, we cannot use this. Um, the thought process is we put it in and it goes through a crevice or a crack, or we've got a hole up in our sinuses and we don't know about it, we could actually be pushing it up into our cranium, which we don't want that. So if there's facial trauma, we cannot use the MPA. Uh, so using the recovery position, preferably left side, if possible. Um, you can do a recovery in the right side. Left side is best. It takes all the pressure off of our aorta and makes it easier for our heart to pump. Used to help maintain and clear an airway of an unconscious patient who is not injured and is breathing on his or her own. So we've got a pulse and we're breathing, but we're unresponsive. We put them in this recovery position. If they do happen to vomit or they're drooling or whatever it might be, gravity will let it run out. Um, and it helps them maintain that open airway on their own. So giving supplemental oxygen. Uh, Always give oxygen to a patient who's hypoxic. If they've got a low sat reading, O2 sat reading, we give oxygen. Some tissues and organs need a constant supply of oxygen to function normally. Never withhold oxygen from a patient who might benefit from it. Supplemental oxygen equipment. So, oxygen cylinders contain compressed gas. Liquid oxygen is becoming more common used alternative. So some of the safety considerations: handle gas cylinders carefully. Make sure the correct pressure regulator is firmly attached before transport. A puncture hole in a tank can turn it into a deadly missile. And secure cylinders when stored on the ambulance and when in use during transport. So we always want to, and there's a skill checkoff sheet for this, you guys will learn. We want to handle those carefully, want to inspect them. We want to inspect our regulators, listen for leaks, check to make sure that our regulator gauge is reading correctly. These tanks are under about 2,000 pounds of pressure per square inch. Um, so a puncture in this tank will literally turn it into a missile. It's like blowing up a balloon and letting it go. As that air shoots out, the balloon shoots forward. Same thing with an oxygen tank. If a hole happens somewhere that air can come out, this thing is going to launch. That is why it's important that we secure these oxygen tanks in the ambulance. We make sure that they are tied down, they're not rolling around, they can't fall over, especially during transport. The pin index system prevents such mistakes as an oxygen regulator being accidentally connected to a carbon dioxide cylinder. Every cylinder of a specific gas has a given pattern and given number of pins. So oxygen has two pins. You guys will see this. Your oxygen bottles are going to have two pins on the bottom side of them, um, or two holes on the bottom side, and your regular has two pins, and they will line up perfectly. That is an oxygen regulator. That is an oxygen bottle. Oxygen bottles are also green. Um, there is a label on them that will identify them as an oxygen bottle. So pressure regulators, so it reduce the cylinder's pressure to a useful range, usually 40 to 70 psi. Final attachment and delivery of gas is either a quick connect female fitting or a flow meter. I don't know if it'll show a picture or not. Flow meter, usually permanently attached to the pressure regulator on emergency medical equipment. Pressure compensate flow meter, burden gauge flow meter. Hazards of supplemental oxygen is combustion and oxygen toxicity. Combustion oxygen does not burn or explode, but it does speed up the combustion process. Keep any source of fire away. Make sure the area is adequately ventilated. Never leave an oxygen cylinder standing unattended. Oxygen toxicity. Um, Not all patients need high concentration of oxygen, which we've discussed a little bit in class. We'll go into detail. Oxygen can have detrimental effects in patients with certain illnesses like COPD. When your pulse oximetry available, tailor oxygen therapy, administer the minimum amount necessary to maintain oxygen saturation at 94%. So we talked a little bit about it. COPDers have evolved, if you will, to where their body does not need as much oxygen. Their body has learned how to function on lower levels of oxygen, higher levels of carbon monoxide. So, if you remember, our body measures carbon monoxide levels. So, everything's kind of reversed with the COPD. If we flood them with oxygen, those pons, those receptors are going to tell our body you've got too much oxygen, you don't need to breathe. So it will actually shut down the respiratory system of a COPD or if we flood them with too much oxygen. It's their body thinking something's wrong and telling them not to take a breath. Um, so the best way to go about this, if they can answer the questions appropriately, find out what their normal is. Their normal might be 91%. And these people know that they have this illness most of the time, and they'll be able to tell you where they're comfortable. 91, 92, 93 acceptable for COPD or anybody else in the natural world. 94 to 99% oxygen on that pulse ox is what we're shooting for. I like to start low, depending on my patient's condition. I treat my patient. Um, if I grab someone and they're struggling to breathe and they're at 87%, I'm going to go a little bit higher. I'm going to go with a non-rebreather. If I grab someone who's at 93 and they're just uncomfortable, I'm going to go with the nasal cannula at 2 to 3 liters and see what happens. We titrate. So we start the lowest that we feel we can and we watch if they need more, we give them more over time. We titrate that patient's oxygen until they are at the point that we are comfortable, or that they feel comfortable. So don't just grab someone at 93% and throw a non-rebreather on them. Go ahead and uh, start low with a nasal cannula and work your way up as you need it. If you end with a non-rebreather at 15, so be it. But we start low and we work through the process to get them to where we need to be. Oxygen delivery equipment. So we've got non-rebreather mask, bag mask device, and nasal cannulas. So non-rebreather, you've got the reservoir bag that we fill up with oxygen. It's going to give a higher concentration of oxygen. We've got the bag mask device. This is where we are actually going to be bagging them or breathing for them. One breath every 5 to 6 seconds, enough to see chest rise and fall. This will tie in, and we'll discuss this later, with our capno because we will be watching to see what our carbon monoxide levels are at. Do we need to speed up? Do we need to slow down? Um, and then we go on to nasal cannula, which is our bottom. It's less evasive. Um, this is going to be 1 to 6 liters per minute. We never go over 6 with a nasal cannula. Um, non-rebreather, I think your book says it's like 12 to 15 or 10 to 15. Me personally, if I put a non-rebreather on, I'm going with 15 liters a minute. Your BVMs, a lot of them will also have a reservoir bag. Hook your oxygen up, turn it to 15. It keeps that bag full. It keeps that high concentration of oxygen being injected into the patient, if you will. So your non-rebreather preferred way of giving oxygen in a pre-hospital setting. Patients who are breathing adequately but are suspected of having hypoxia, combination of mask and reservoir bag. So this is your non-rebreather. It's got your face mask, it's got a reservoir bag, it's got a holding strap, and then it's got your oxygen tubing. Make sure the reservoir bag is full before placing it on the patient. Adjust the flow rate so the bag does not collapse when the patient inhales. When oxygen therapy is discontinued, remove that mask. Um, Nasal cannulas. So deliver oxygen through two small tube-like prongs that fit into the nostrils can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6. So I'll step back for a minute. Right now, you and me are breathing at 21% oxygen. That is what the oxygen concentration in the everyday atmosphere is 21%. So when we apply this non or the cat when we apply a nasal cannula, and they are taking oxygen in, it's 24 to 44% oxygen in that atmosphere for them. 1 to 6 is where we go with that. Um, these are the ones that we can coach. I'm a firm believer in coaching patients. We want to tell them, breathe in your nose, out your mouth. Sometimes you might be telling them this every breath. Ask them, do you feel the oxygen's helping you? Watch that pulse ox, see what's happening on their oxygen percentage. And like I said before, we titrate until us and the patient show improvement and we feel comfortable. Used in patients with mild hypoxia, a patient who breathes through the nose or has a nasal obstruction will not benefit. This is why if they breathe through the mouth, we need to coach them. If there's a nasal obstruction of some kind, we might have to do a different process. We might have to use I call them a simple mask, with no reservoir bag, or we might have to do blow by where we just hold the oxygen next to them. Um, when you anticipate a long transport time, consider using a humidifier. So if we're blowing oxygen through a nasal passage, our nasal passages dry out very quickly. If you remember, we use those to warm and humidify oxygen when we breathe in. So sometimes if you're going to be looking at, I'm going to say 4 hours or more, you're going to want to put them on a humidifier. And all that is the humidifier is a bottle of saline that hooks to our oxygen. Um, and then our tubing hooks to that so that we have a little bit of uh, humidity going through that oxygen tubing as they breathe in. It keeps those sinus passages moist. Let's see, partial rebreather's mask, similar to a non-rebreather mask. There is no one-way valve between the mask and the reservoir. Patient rebreathe a small amount of exhaled air. Um, I personally have never used one of these. Um, the ventral mask, a number of settings can vary percentage of oxygen while a constant flow is maintained, delivers 24 to 40%. So each one of them little plastic pieces can be inserted and each one gives a little bit different amount of oxygen. The tracheostomy mask, patients with a trach do not breathe through their mouth or nose. They breathe through that little hole down there in their throat. Tracheostomy bag mask covers the trach hole and have a strap that goes around the neck. May not be available in an emergency setting. Improvise by using a face mask placed at the trach site. So a lot of these, if you're doing an adult, use a pediatric mask and it will actually fit right on an adult throat pretty easily. And you can kind of hold pressure there, not hard, to keep a seal, and they are able to receive oxygen that way. Assisted or artificial ventilation. So basic airway and ventilation techniques are extremely effective. Follow standard precautions as needed when managing a patient's airway. Signs and symptoms of inadequate ventilation. So, altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. When assisting with a bag mask device, explain the process to the patient. If they're alert, we need to talk to them. I can't say this enough. We coach our patients through everything we do. Explain the procedure to that patient, what you're doing and why you're doing it, what it's going to feel like. Place the mask over the nose and mouth. Squeeze the bag each time the patient takes a breath. After the initial 5 to 10 breaths, deliver an appropriate tidal volume. Maintain an adequate minute volume. So this is talking about patients who are awake. They're breathing on their own, but they're not breathing adequately. Um, we need to tell them exactly what we're doing, and every time they take a breath, we need to give them a little oxygen. We need to squeeze that bag. We're watching for chest rise and fall. And then slowly we can try to adjust their breathing pattern to get them to where we need it. We want that good chest rise and fall. We need that 12 to 20 breaths per minute going in. And once again, Look at your pulse ox. Are you delivering that oxygen and is it being diffused through the body like it's supposed to be? Artificial ventilation, once the patient is not breathing, begin artificial ventilation immediately. Mouth to mask technique, 1 or 2 person bag mask device. Normal ventilation versus positive pressure ventilation. So in normal breathing, the diaphragm contracts and negative pressure is generated in the chest. So we contract, our diaphragm contracts, I guess. Everything opens up, air comes into the lungs expand. Positive pressure ventilation is generated by a device that forces air into the chest cavity. So we don't want to just be hammering that bag every every 5 to 6 seconds. We need to give the proper amount of air. We want chest rise and fall. Um, and we want to count our breaths. If you are giving ventilations, that is your one job. Your job is not to be doing 10 different things at once. If you're in charge of that bag, you are literally have one job. You breathe, chest rises and falls out loud. 1, 2, 3, 4, 5. Breath, and we start over. Count out loud. That is your one job. Block out everything else that's going around you. As a beginner EMT, it's really hard because you want to watch all the fun stuff happening. Just remember, your one job is to breathe for this person. With positive pressure ventilation, increase intrathoracic pressure reduces blood pumped by the heart. More volume is required to have the same effect as normal breathing. Air is forced into the stomach, causing gastric distension. So as we're breathing for them, we also kind of need to glance every once in a while at their stomach. Make sure we're not blowing up that stomach. If we are, do not push on it. When we get gastric distension, we are going to get vomit. They are going to throw up. So have suction ready and be prepared for that. Mouth to mouth and mouth to mask ventilation barrier devices is routinely used in mouth to mouth ventilation. Mask with oxygen inlet provides oxygen during mouth to mask ventilation. Um, we really we don't do mouth to mouth anymore. That's kind of frowned upon. You can if you absolutely want to. Mouth to mask, these are those little rescue masks that we've all seen. I would probably use one of these if I had to. Just be just be mindful of what might happen because you might get vomit, you might get blood secretion, whatever. Um, So a bag valve mask, it provides less tidal volume than a mouth to mask ventilation. An experienced EMT can provide adequate tidal volume. So you'll notice we've got our face piece, our mask. It needs to have a nice tight seal, which we'll discuss how to use that EC technique. We've got our balloon, our ball. Um, this is where we're going to squeeze, and this is what pushes air through here into the patient. Then we've got our reservoir bag. So you see the oxygen tubing plugging in here. It fills this bag with 100% oxygen, and we can actually give high concentration oxygen every squeeze we give, every breath we give. Gastric distension occurs when artificial ventilation fills the stomach with air. Most likely occurs when you are ventilating a patient too forcefully or too rapidly. May also occur when the airway is obstructed. So we're bagging too hard, we're bagging too fast, um, or we're not getting into our lungs. We're actually going more or less down the wrong hole and we are blowing that stomach up. To prevent or alleviate distension, ensure the patient's airway is appropriately positioned. This can be done by one, watching our Capno. At this point, we're going to be using what's called Capno N-Tidal, which we'll get into. Um, we can also watch that chest rise and fall. We can also auscultate lung sounds. We can listen to make sure that air we give is going into the lungs. Ventilate at an appropriate rate for an adult, 5 to 6 seconds. One breath every 5 to 6 seconds. Ventilate with appropriate volume. And if the stomach appears distended, recheck and reposition the head and perform rescue breathing. Um, Auscultate those lung sounds. Learn to listen for air movement within the lungs. Passive ventilation, expansion, and contraction creates a pump for air movement, benefits patients who are receiving chest compressions, can be enhanced using the oropharyngeal airway and supplemental oxygen. Automatic transport ventilator, manually triggered device attached to a control box allows the variables and ventilation to be set. Lacks the softest, yeah, I can't say that, control of a hospital ventilator, and frees the EMT to perform other tasks. So automatic transport ventilator, they breathe it's a machine that breathes for them. It's a ventilator. Um, we hook it up, we can dial in the exact amount of air we want pushed in, how often, um, and it allows the EMT to go ahead and do other things that are needed. I personally have been doing this for 6 years. I have never had to use a ventilator, but who knows? There's always that first time. So CPAP, non-invasive ventilatory support for respiratory distress. A lot of people use CPAPs. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night, becoming widely used at the EMT level. I love the CPAP. Um, the mechanism, uh, increased pressure in the lungs. It opens collapsed alveoli, pushes more oxygen across those alveoli membranes, and forces interstitial fluids back into the pulmonary circulation. So we have, and you can check me on this because I could be wrong, uh, 480 million alveoli. That's 240 million per lung roughly. We don't use all of those all the time. Once an alveoli is destroyed, it's destroyed. It can't be replaced. It doesn't heal. So what CPAP does is it actually forces our unused alveoli or our alveoli that are struggling to open. It forces them more open, so more oxygen can get on them alveoli and diffuse into them. And then any fluid that we've got in there that might be affecting our respiratory, our breathing at the alveoli level, it actually forces that fluid back away from them, opening up or allowing that oxygen to reach more alveoli. Therapy is delivered through a face mask held to the head with a strapping system. Use caution with patients with potential low blood pressure. So this you're going to learn your contraindications, but they have to be awake, alert enough to follow simple commands. Um, and their blood pressure has to be, I think it's above either 90 or 100 systolic. Um, I have used the CPAP a couple times and it has been night and day with my patients. Um, Watching it actually do its job is amazing. So indication, patient's alert and able to follow commands. Patient displays an obvious sign of moderate to severe respiratory distress. Respiratory distress occurs after a submersion incident. Um, Patient is breathing rapidly. Pulse oximetry is less than 90%. Contraindications, patients in respiratory rest, which means we're not breathing. It's not going to work then. Patient is hypoventilating. We don't want to do it. Patient cannot speak. Patient is unresponsive or cannot follow verbal commands. Patient cannot protect his or her own airway. Patient is hypotensive. So they have low blood pressure. They're not able to breathe on their own. They're not keeping that airway open. They're unresponsive. They can't follow a command. We don't use it. With CPAP, we have to, I guess there's more indications. We have to really coach these patients. Signs and symptoms of a pneumothorax or a chest trauma, we don't use it. Patients have a trach, um, active gastrointestinal bleeding or vomiting, patient has experienced any type of facial trauma, patient is in cardiac shock, patient cannot sit upright, or patient cannot tolerate the mask. We do not use it. Application resistance creates back pressure that pushes open smaller airway structures as the patient exhales. Uh, 7.0 to 10.0 H2O is acceptable. We're not going to worry about that too much right now. Uh, Complications, some patients may find CPAP claustrophobic. Risk of a pneumothorax can lower the patient's blood pressure. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using a bag mask device. Um, this is why we have to coach these people. We've got to explain every single step before we do it. Um, the CPAP mask, literally, it's got a piece that comes across your forehead. It's got the full face mask. It wraps clear around the back of the lower and upper skull. Um, so you're literally like strapping this monster thing to their face, and it is um, constantly like blowing air. It's forcing air into them or oxygen into them. So it does feel uncomfortable to these patients. If you can coach them, explain them, within a couple minutes, you should start feeling some improvement. Watch that pulse ox. Um, Continue to monitor that patient. If if we're putting too much pressure on weakened lungs, we can cause a pneumothorax, which is we'll get into. We probably already have talked about it, but we'll talk about it more. Um, we can actually get air. We can puncture a lung. We can cause barotrauma. We can get air outside of the lung, which is going to put pressure on the rest of our organs. Um, it lowers that blood pressure. Okay. If at any time that patient becomes starts to deteriorate or it's not helping, remove that CPAP and let's try the try to bag them. Stomas or trach tubes, patients who have had laryngenic, I can't say that here, who's had a stoma put in. Um, these are considered special considerations. Stomas and trachs. Neither a head tilt chin lift or a jaw thrust maneuver is required because the tongue doesn't fall that far back. Patient has a trach tube. Ventilate through the tube using a bag mask device. If a patient has a stoma but no tube, use an infant child mask, which we talked about. If you're unable to ventilate them, try suctioning that stoma out. Try to clean it. A lot of times they will have a lot of phlegm in them. Seal the stoma while giving mouth to mouth. Airway obstructions. If a obstruction completely blocks the airway, it's a true emergency. Will result in death if not treated immediately. In an adult, usually occurs during a meal. In children, it can occur while eating, playing, or small toys crawling. Um, Anytime you go on a kid with a possible airway obstruction, you need to just assume that they've put something, money, food, toy, whatever in their mouth, and it's got lodged. Uh, so we've talked about the tongue is the most common airway obstruction in an unconscious patient, causes the airway obstruction. Uh, do not involve foreign bodies is swelling from infection, acute allergic reaction, anaphylactic. Trauma, tissue damage, or injury can cause that swelling. Mild airway obstruction, patient can still exchange air, but will have respiratory distress. You might have noisy wheezing, coughing. With good air exchange, do not interfere with the patient's efforts to expel the object on his own or her own. Go ahead and coach them. Tell them they need to try to cough. Um, Tell them this sounds morbid. Tell them I want you to cough so hard that you feel like you're going to vomit. That's what we're going for. We want them to expel it on their own. Um, with the mild airway, you've got poor air exchange. The patient may have increased difficulty breathing, stridor, or cyanosis even. So treat immediately. We're still coaching them. You can pat them on the back. Um, but then we get into that severe. Um, so if mild turns into severe, this is when patients cannot breathe, talk, or cough. Patient may use the universal distress signal, begin to turn cyanotic, and have extreme difficulty breathing. They are going to be in a full-blown panic at this point. This is where we can step in, provide immediate treatment to a conscious patient. If not treated, the patient will become unconscious and die. If the patient is unresponsive, not breathing, and has no pulse, begin CPR with chest compressions. So, mild, we coach them. We try to get them to dislodge whatever object it is on their own. As soon as it becomes a severe, they quit making noises. This is where we're going to start those abdominal thrust or the Heimlich maneuver. Same thing. When they go unresponsive, we move them to the ground as softly as possible and we begin CPR. The whole purpose of abdominal thrust and CPR is we are causing pressure within the thoracic cavity or abdominal cavity, and that pressure is hopefully going to dislodge, it's going to push up and dislodge that object. Emergency medical care for foreign body airway obstruction. Perform head tilt chin lift maneuver to clear the tongue obstruction. Large obstruction should be swept forward out of the mouth with a gloved finger. Abdominal thrusts are the most common effective, we talked about. Um, Once they go unresponsive, we begin CPR. Dental appliances can cause airway obstructions. Examples: crowns, bridges, dentures, and pieces of braces. Manually remove the appliance before providing ventilations. We don't want to push it further down. Leave well-fitted dentures in place. If they're loose, go ahead and try to remove them the best you can. Facial bleeding. Airway problems can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich. Face and head trauma, you're going to get lots of blood. Injuries can result in severe tissue swelling and bleeding in the airway or into the airway. Control bleeding with adequate pressure and suction as needed. Just be careful that if you're controlling bleeding, like in the mouth or something, that we're not filling the mouth with gauze or blood stop or something like that. This is where suction. Now, if it's like a broken off tooth, yeah, we can put a 2x2 or something in there and hold pressure, have them bite down on it, something like that, just like a dentist would. Um, Otherwise, we need to suction and keep that airway open. Placement of an advanced airway, pre-oxygenation, equipment setup, perform the procedure B-Magic. So perform bag mask, pre-oxygenation, evaluate airway difficulties, manipulate the patient, attempt first pass intubation, use a supraglottic airway if unable to intubate, confirm successful intubation, correct issues. So, um, anytime that we're going to be doing an advanced airway, whether it be an advanced or paramedic doing a ET tube, or it's going to be an EMT or advanced or paramedic doing a supraglottic, the steps we got to follow is we have to pre-oxygenate them. So we're going to put that oxygen at 15 liters on our BVM and we're going to oxygenate them. We're going to almost hyperventilate them to get their oxygen saturation as high as we can. We'd prefer 94 or above. Um, Evaluate the airway difficulties. Is there swelling? Is there foreign bodies? Is there, are we suctioning? Manipulate that patient. So we want to get that head tilt chin lift or whatever we need to do. Um, Manipulate the body so that we can attempt this airway. Attempt your first pass intubation. So this is going to be advanced or paramedic. We're going to attempt that first pass. If we, for some reason, are having trouble, then we can use a supraglottic, which is going to be an iGel or a King, which you guys are going to get to learn how to do. Um, And then we're going to confirm it with some simple things. We're going to put an end tidal CAPNO device on. We are going to auscultate lung sounds and listen for that air movement when we ventilate them. And we're also going to use our pulse ox to see if we are raising that oxygen level. Um, we can also look at things like skin color. Is it improving? Are we getting oxygen in there um, and nutrients so we can feed those cells? So we take someone who's really pale and we start oxygenating them after we intubate them or whatever. Are they pinkening up? Are they showing improvement? So breathing is controlled by an area in the yes, it's the brain. The pons and the medulla are the respiratory center in the brainstem that controls breathing. We talked about this in chapter 6. The EMT should assess the patient's tidal volume by observing for adequate chest rise and fall, assessing the facial area for cyanosis, continuing the patient respiratory rate, or counting the respiratory rate, or measuring the patient's oxygen saturation. We're going to check tidal volume, the volume of air that's moved in and out of the lungs in a single breath. So we watch that chest rise and fall. In a otherwise healthy individual, the primary stimulus for breathing is C. Remember that under control of the brainstem, rising levels of carbon dioxide in the arterial blood normally stimulate breathing in an otherwise healthy patient. We measure carbon dioxide. Signs of adequate breathing in adult include all of the following except. So we're going to really start practicing on how to take tests. I know we've talked about this before. So signs of adequate breathing in an adult include all the following except. Got it? Yes. B. There's your accept. Signs of inadequate breathing in an adult include a respiratory rate of 12 to 20, shallow chest rise and fall, reduced tidal volume, cyanosis. Um, so we want to see pink, warm, dry skin. We want to see equal chest rise and fall. We want that respiratory rate 12 to 20. During insertion of an oropharyngeal airway into an unconscious patient, she begins to vomit. The first thing you should do is to remember if we're putting an OPA in and that patient gags or vomits, we need to be, oh, I told you wrong. Turn the patient on her side. We need to remove the OPA and turn the patient on her side. Um, boy, I got that one wrong, didn't I? So I guess I'll explain myself. OPA, I'm inserting an airway. I begin to put it in and they begin to vomit or gag. I take that out and then we need to turn them over to get the vomit out. In which of the following patients would a nasal pharyngeal airway be contraindicated? Patient with patient who failed 20-foot on. Okay. Um, I'm gonna go with C. So nasal airway, the MPA. Remember, no facial or head trauma. We cannot use it if there's facial head trauma. You're delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he begins to complain of burning sensation in his nose. You should remove, apply an underbreather, attach oxygen humidifier, decrease the flow. Well, there's okay. C, add that humidifier. They need the oxygen, so we can't just take it away from them. So if we're getting a burning sensation, it's because they're drying out. Their nasal passages are drying out. So we add that humidifier. It moistens that oxygen. A patient is found unconscious after falling from a third floor window. His respirations are slow and irregular. You should. So look at the hidden words in there. His respirations are slow and irregular. I'm going to assist with ventilations. When ventilating an apneic patient with a bag mask device, you should squeeze the bag. D. We're looking for chest rise and fall, one breath every 5 to 6 seconds. You and your partner are ventilating an apneic adult. When you notice that his stomach is being distended, you should remember it said that we need to reposition that patient's head. Maybe our airway is being blocked. So B. All right, guys. So we got through that chapter. We're gonna go really deep into class on hands-on on a lot of this, but our next one is respiratory emergency. So it's gonna tie right into this one. I will see you shortly.